Hi, good evening. According to UAE time, dear respected guests and audience, I am Amar Al-Hamadi, internal medicine consultant and vice president of Emirates Society of Internal Medicine. The subject of this webinar is COVID updates, lessons learned from the experts. It's my pleasure to welcome three very distinguished clinicians who worked very hard during the pandemic from day one in Emirate of Abu Dhabi, and what they have done were reflected on the remarkable achievements they have accomplished. In this session, we want to learn from their experience, and we will have three segments. Each speaker will have around 20 minutes. Then we will open the floor for Q&A for another 20 minutes. And then you may leave your question in the text, and I will make sure to deliver all the questions to the speaker if the time allows us to do so. We may take a few verbal questions as well. So I will introduce each speaker before his or her segment. So allow me to introduce the first speaker, Dr. Nawal Kaabi. Dr. Nawal Kaabi, she graduated from United Arab Emirates University in Al Ain. She is American and Canadian board certified in pediatric, and she is also certified as infectious disease physician by the Royal College of Physicians and Surgeons in Canada. She has completed an infection control fellowship at University of Ottawa. She is chair of UAE COVID Clinical Management Committee, and she is chair of SAHA Infectious Disease Council. Currently, she is a pediatric infectious disease consultant, chief medical officer of Sheikh Khalifa Medical City in UAE. She is lead of COVID trial in Abu Dhabi. So Dr. Nawal will talk about COVID vaccine updates from UAE experience. Dr. Nawal, please, you have the mic right now.
Thank you, Dr. Umar, for the introduction, and I'm honored to be here with you today. Can you see my presentation?
Yes, Doctor, we can see it. Inactivated SARS-CoV-2 vaccine, right? Yeah, we can see.
Yes. Okay, thank you. Assalamu alaikum, everyone. So, as inspired by UAE leadership vision and commitment to overcome the pandemic through global collaborative efforts, a clinical cooperation agreement was signed between the Chinese pharmaceutical giant Sinopharm Group and Group 42 Healthcare. The Group 42 Healthcare will sponsor the agreement that they will sponsor the phase 3 clinical trial in UAE, and the clinical trial are being conducted under strict guidance and supervision of Department of Health and Ministry of Health of UAE. SAHA is currently leading the clinical trial in Abu Dhabi, and Ministry of Health are leading it in Sharjah. Uh, Initially, when we announced the trial on July 16th, at that time, two of our healthcare leaders, Sheikh Abdullah Al Hamid and Dr. Jamal Al Kaabi, the Undersecretary. Sheikh Abdullah is the chairman of Department of Health, participated in the trial, plus another 13 people. On the same day, we received so many requests, actually several thousands within 24 hours. So we decided to move to another site instead of doing it in clinical site or hospitals. We decided to move to ADNIC. So now I will go through a virtual tour with you.
Dr. Noel, can we make it slideshow, please?
Thank you. This is our functional flow chart. As you know, to run such a very large clinical trials, it's almost like running a hospital. So we have physician leads, pharmacy lead, lab lead, operation lead, nursing, IT, and infection control. If you look at the previous publication of the same vaccine, it is inactivated vaccine. So this is one of the advantage that for this vaccine, as this is a well-known technology being used for many years in the past, and all of us knows the long-term side effect and the common side effect with inactivated vaccines in general. So in the preclinical, it approved that it is immunogenic, produce antibodies without significant side effect in the animals. Then it was followed by to another publication. This is the interim analysis of phase one and phase two, and this is the final analysis of phase one and phase two. And again, the vaccine approved to be to produce antibodies and without any significant side effect. This is the study design. It is a randomized control trial, double blinded, and the sample size 45,000 volunteers in all sites. The primary objective is to evaluate the protective efficacy against COVID-19 of inactivated SARS-CoV-2 after 2 doses of immunization. The immunization schedule, 2 doses, 21 days apart with a window period of plus 7 days. So anywhere between 3 to 4 weeks. And the age group, of course, more than 18 and above, healthy individuals. Laboratory testing, we are doing a nucleic PCR for each volunteer before enrollment. We don't wait for the result. If they are clinically well, we go ahead and give them the vaccine if they consent, and we collect a blood sample from all subjects before the vaccination and 14 days after vaccination. And from a subset of a group, about 900 per site, we collected around 28 days, 3 months, 6 months, 9 months, and 12 months after the vaccination to see for how long the antibodies will last. This is our trial endpoints for safety and efficacy. So for safety, we observe the incidence of any adverse reaction within 30 minutes, and then we observe adverse reaction after vaccination. And we observe the incidence of serious adverse event from the beginning of the first dose to 12 months after the whole course of immunization. Now, the serious adverse events, there is a specific criteria. So any admission will be counted under serious adverse events, whether it's related to the vaccine or not related. The efficacy, we evaluate the fourfold increase in the GMT and GMI 14 days after the full course. And then we have other endpoint for protective effect against symptomatic
Dr.
COVID.
Noel, sorry, can we make the presentation on full screen?
Actually pressing on the full screen, somehow it doesn't show. I don't know why. Not sure.
Could you please press F5?
F5. Okay. Nothing happened.
F5. First click on your presentation, then press F5.
Okay. I did. Okay, now?
Yes, yes, doctor.
Okay. So the secondary endpoint to evaluate the protective effect 14 days after 2 doses of preventing severe cases. So the first one, any symptomatic cases. The second is severe cases or death. and the exploratory endpoint to explore the protective level of anti-SARS-CoV-2 neutralizing antibodies. This video will show you the journey of the volunteers. Again, this summarizes the full journey of our volunteers. In terms of different sites, Abu Dhabi started July 16, followed by Al Garain in Sharjah 5th of August, then Kingdom of Bahrain 19th of August, Jordan 27th of August, and Egypt 17th of September. If you see in Abu Dhabi, we enrolled 26,571, so this is the largest site, 87% male and 13% female, and 33% are Emirati and 67% expats. Actually, among the expats, we have 125 nationalities, and the main side effect are mild side effects. Major one is pain at the site. The most common one is pain at the site of injection, followed by headache and body ache. Of course, we are monitoring the cases, and Dr. Jihad in charge of those cases. Both we are doing passive and active monitoring, and initially we used to do lots of PCRs for all our volunteers. Now we are focusing mostly on the symptomatic, but we run a report both at Saha level and at the national level to capture anyone with positive COVID. As you know, in UAE, we have a single platform. It's called Al Hisn, where all results within the country can be captured within that platform. So wherever the patient are diagnosed or volunteer will be able to capture the result. So we recruited in all sites over 43,000. Side effects are mainly minors, and the most common, as I said, pain at the injection site. The first interim analysis has been done by DSMB and approved, and we are now waiting for China Drug Authority approval. I think many people are wondering if the results are ready, why it's not released. With a China system, it's a bit different than the Western system, where the pharmaceutical cannot release any result prior to the government approval. So we are waiting for the China Drug Authority approval. Emergency authorization, it's been authorized in China, and they vaccinate over 1 million without any significant side effect. In UAE, it's been authorized 14th of September. And recently it's been fully registered, and we diagnosed many people. Again, we are monitoring the side effect, we are monitoring the positive COVID, and I can tell you that our results are actually excellent. UAE on 9th of December announced the registration of the vaccine. Based on the interim analysis, it's 86% efficacy against not COVID infection, against symptomatic COVID, and it is 100% against severe COVID, and 99% seroconversion of neutralizing antibodies. In UAE, we recruited 31,000 in total with the Sharjah with 125 nationalities. This is our amazing team. Thank you so much, everyone.
Wonderful. Thank you very much, Victoria Nawal, for this nice presentation. I already received many questions regarding the vaccine, but I will leave it until the end of the webinar. So now we will move to Dr. Sajja Shaheen. Dr. Sajja, she did her internal medicine residency at the University of California, Los Angeles, UCLA. She was a medical director in Southern California before returning to UAE. She is a member of the leading physician of the world, and she has been awarded many awards, including US Top Physicians, as well as Sahha Leadership Award. During the pandemic, she was acting chief of medical division in Al Rahba Hospital and later on Mafraq Hospital. So she is going to talk about the pandemic impact on the inpatient service in our hospital. Dr. Sajja, please, you have the mic now.
Thank you, Dr. Omar, for the introduction. Good evening, everyone. And thank you again for having me. So let me share the screen. Is this good? So when COVID hit,
Yet.
All hospitals around the world rolled up their sleeves, basically. And since early, yes?
Presentation is not shared.
Yes,
can you see it?
Yeah.
Open the presentation first, then click on share screen.
Okay, hold on.
And double click on the presentation.
Hold on one second. So, is it good?
No. The presentation is already open, Dr. Sajja.
It's open?
Yes. Then back to Zoom and click on share screen.
Now I've clicked on share screen, but it's not working.
You can see your presentation or not?
I can see my presentation.
Yes. Now it's shared. Great.
Yes.
Now it's shared?
Yes.
Yes.
Okay. So let me move on. So when COVID hit, basically the physicians, the hospitals around the world rolled up their sleeves to care for all those COVID-19 patients. It started early spring, but for us it was actually end of January. They basically started and initiated those testing centers and purchased ventilators and PPEs in bulk. They've actually bulked up on their medication, added intensive care unit beds, and increased their square footage to accommodate for all that large number of patients. And at Rahba Hospital, we did the same. We worked proactively and immediately to care for those patients. One of the biggest reasons that we've actually done well is because we were backed up by a great government. I mean, our government saved no time in rolling up all those guidelines from DOH, MOH, and some key members there that I would like to thank tremendously, because if it wasn't for them, like Dr. Nawal Kabi, we would have been lost. And now, just a little bit of background, we've actually had Al-Rahba Hospital was in the process of being decommissioned. It was a secondary hospital, and it was starting at the beginning. We were at the beginning of a Rahba Hospital development project. We had to do that pretty fast. We had to decommission the whole, all the units, and we've achieved that in record time. At that point, we were caring for actually 2 hospitals. Al-Mafraq Hospital was also decommissioned, but we had to commission it again. And we had to also continue the development in Al-Rahba Hospital. But our staff went on missions to do a few screening missions all across the Emirates of Abu Dhabi. One of the key teams that obviously played a huge role is our infection control team. And they've played a huge and tremendous, basically roles in guiding us and helping us throughout the establishment of all things clinical and non-clinical pathways, helped in the establishing of the order sets from SAHA, established admission protocols, and for receiving those suspected and confirmed positive cases, established the negative pressure rooms, the addition of negative pressure rooms through a negative pressure technology. I think pretty much everybody did the same, the HEPA filters, because not all the hospitals were negative pressure rooms. Established code Delta for patients' admission and discharges and movement within the hospitals. They've also established designated routes and elevators for positive patients. And we pretty much assigned roles to everybody from physicians all the way to allied staff. We stocked up on the medication, but I would have to say that our one of our strengths is that we realized earlier on that we have limited amount of basically manpower, and they are our greatest assets. So we had to go ahead and protect them. And we rolled up 2 occupational health clinics in both hospitals with occupational health pathways. Immediately right after that, we've established the hospital incident command system on both hospitals. We activated both, and led by our incident commander. We would go into those meetings for hours on end, and it would last about 1 or 2 hours, but it wasn't just a meeting, it was where things got done. And one of the moments that I remember is that I would leave my cell phone in the entry room, I would go examine a patient, come back, and the meeting was still going on. And it would basically tackle everything from patient safety all the way to even patient menu. We would report to our incident commander, and one of the few achievements that we've done is that we've allocated and created additional ICU rooms, as well as monitored bedrooms, because not all hospitals are obviously monitored bed. Allocated also and added the negative pressure technology to it. We've established the discharge team. Having to discharge 100 patients a day was not an easy task safely. We've also established the recruitment process because of the limited manpower that we've had. And not only that, but we had to also monitor the great effort that was led by our education team to basically monitor all their training of all those new recruits. One of the other things that was accomplished by our HICS team is that they've created a dashboard whereas they've overseen all those patients from hospital to hospital and bed allocation, what have you. But the emergency the emergency center at SAHA actually played a huge role in guiding us. So huge thanks to them for assisting us also through and assisting our other sister hospitals through this whole process of patient admission and discharge to quarantine facilities. But one of the also important things that we've done in addition to all of those is actually establishing a patient happiness program. And as you all know, those patients were terrified, full of fear, being admitted in those rooms for 7 to probably 14 days at a time. So anxiety level and stress level were high, and it was our job to basically just calm them down and attend to all their needs. At least we tried. And one of the things that, one of the best things that we've done is actually we've offered tablets to all of our patients at Rahba. We've actually also offered mini fridges that is full with refreshments and also healthy snacks. One of the things that I remember one of our physicians, our beloved physician, I think he's probably joined us, has done is that we've recognized one of the patients that kept complaining, and he was sick and he was upset, and he was of a certain ethnic background, and it was his birthday. So that physician went on and to a bakery of the same ethnic background, bought him and purchased him his cake and celebrated his birthday. And that really, really went far, and the patient was very happy. But mostly and most importantly is that our achievement was mainly also clinical, and that's the real deal. I give kudos to our team. We have an amazing team, and special and big thanks to Dr. Nawal again and Dr. Jihad, because honest to God, without them, we would have been lost. They've guided us through all this process with the early introduction of antiviral. And that was crucial. And we've monitored that introduction to be introduced, and all antiviral to be introduced within the first 24 hours of patient admission. But one of the key things that we've done also is that we risk stratified those patients into low, moderate, and high risk. And the key introduction of early CT scan. The lung CT scan played a huge role, and our radiologists have been amazing in live reporting all those moderate or severe CT scan and alerting us as such to those patients. One of the other things that our team has done, which I thought played a huge role in our success, is that the team came to the senses that, okay, those patients, before we even knew about COVID being a thrombotic state, we came to the consensus that those patients are locked in a room, they're in isolation, and they're not moving a lot. And if there's no contraindication, let's go ahead and start them on anticoagulation. And once the more and more data came about COVID, and with the anticoagulation, we've introduced that and upgraded our treatments. One of the other things that we've done is basically that we've screened those patients also for anxiety upon admission and depression with the psychiatry screening on day 1 and day 7, and also in certain individuals before discharge. One of the other clinical things that we've done that played also a huge role in discharging those patients safe and fast is that we've introduced the concept of proning those patients with moderate to severe disease, even though they did not need oxygen. And I think more and more data are coming to support that practice. The usage of telemedicine and I would say the tele rounds have helped us tremendously to safeguard our physicians, especially that earlier on we would admit only asymptomatic and mild disease patients, and those individuals did not need to basically be rounded on every day. So for that, we use the tele round. We will call them and video conference them, make sure that they're all okay, and attend to their needs, especially with the limited manpower that we've had. So the timely assessment of our patients and prioritizing all those patients have helped us tremendously. But we've also allocated those moderate and severe patients in certain units in the hospitals in order to recognize them and attend to them and perhaps round on them more frequent. We've allocated IM physicians to only round on those patients, but non-IM would round on the less severity, but being still supervised by IM physicians. We've created the concept of the physician lead, and that actually served us well, given the limited manpower that we've had, especially the limited IM physicians that we've had. One of the things that I thought was a best practice in Rahba too is that we've had a few physicians and nurses that actually could not, because of health reason, could not be in direct contact with our patients for their safety. So we got them to work, and they loved it, and they did a great job. What they've done is basically we would have them monitor our VTE and the compliance with the anticoagulation from our physicians by those physicians and those nurses that would work 24/7, 7 days a week. And not only that, but also in the early era where we use hydroxychloroquine, we would also monitor the ECGs for those patients to make sure that they were read, make sure that there's no QT prolongation, to double check on that work, not to miss anything. One of the things that those group of physicians also have done is that they would monitor the clinical pathways, and as well as our adherence to those order sets that were created to make sure that nothing was missed. And we did well, actually. We did very well. We had only a handful of patients that end up with venous DVT, and I believe only a few patients end up with PE. So we, given the large number of the patients that we've admitted, we've done well. We needed to uplift the spirit for our staff, so we buzzed them up with coffee and refreshments and chocolates and all the fun stuff that they needed, but they much deserved it. They've rolled up their sleeve and they've done a great job. But Sahha also helped us tremendously with the introduction of the psychological support to our staff. So that actually, together with all those practices, have really helped us. One of the things that I really would like to shed light on is the protected code blue. And that is a concept that was probably many of you know was started back in the era or the time of SARS and also Ebola, when a lot of healthcare workers end up contracting the disease after being exposed after a code blue. And what it is basically a modified version of the code blue for the code blue and or other aerosol generating medical procedures as such to reduce or minimize the risk of exposure to our health staff, healthcare workers. And things like, you don't just rush to the code blue, you would have to gown up and dress, basically put on your level 3 PPEs. The other things is like if you've seen a patient with a cardiac arrest, you don't just go and listen and get close to the patient, but it was mainly a hold on and don't do those knee-jerk reflexes that you would normally do with a code blue. The other thing is that to have someone who is very skilled and practiced so many intubations to do the procedures like intubations in order to minimize exposure. One of the things that I mentioned also was of RAHBA best practices was the video conferencing. And those things came in handy, especially for those tele rounds that we've mentioned, but also they came in handy with the delirium that we experienced also with some of the elderly patients. We would have their families call and visit them through basically a video conferencing, but we've also had to monitor some of those high-risk patients also through those cameras. Our team had fun, and our team were ready to just do everything, and they were having fun at all times, and I think that's what kept us going. That's what really kept us going. But I would like to shed some lights on the physician manpower utilization model that we've had, because earlier on, we've really had an extreme shortage. Here we are, a secondary hospital with limited IM basically department, only about less than 20 physicians, having to cover 400 beds in both hospitals. So it was a huge task, but we stepped up to it. And what we've done initially was 23 patients to 1 physician, and most of those were non-IM because we had to allocate the IM as in a supervising powers. By the end, I would say by near the surge, we've actually got the help from the government and also from Sahha, and they were great. They send us a huge amount of physicians, and the ratio came down to comfortably and safely to 10 patients for one physician. One physician for 10 patients. And that made a huge difference. But I can say that a lot of them during the surge worked 7 days nonstop. And I think this goes for most hospitals around the UAE. Of course, the challenges were huge, but the biggest challenge I think that we've had to face was the manpower. The manpower shortage was the biggest, I think, for all departments. And not only the manpower, but having to even train those new recruits now. And not all nurses were ICU nurses and not all doctors were IM doctors. So we had to upskill some nurses and physicians, as well as allied even with clinical pharmacy being in need. So those are mainly the challenges. By no means we've had any deficiencies or shortage in medication, ventilators, or square footage. The government have done a great job. And I think we were so lucky to be here with all the support that we've gotten. Now, I'm not going to go through all the nursing accomplishment, but kudos to our nurses all around the world, honestly, but special kudos to our nurses because they were the cornerstone and they were the stars of this pandemic. They really did a great job. I do want to mention the discharge. I want to highlight the discharge team that we've started. And I think that was one of our biggest strengths, given the fact that we had to admit 100 patients, almost large number of patients a day, and have to discharge just as much. And that clinical decision had to go on 24/7, 7 days a week. So those same physicians that had limitation, we've assigned them to actually be on call 24/7 with shifts, nights and days and weekends to review the charts, to make sure that, to make the recommendation also to the consultants that those patients are ready to be discharged, to make the recommendation to which discharge facility and which quarantine facility that they should be discharged to also make sure that the discharge summaries and medication were reconciled and done. We had to do all that before noon every day. So that was a huge challenge that we've actually met very well. Now, I have touched on that, the infection control team being a great team and have helped in a tremendous amount of way, and we can't thank them enough. But one of the things that we had to deal with is that we were called upon to open a COVID hub. And in it, we had to receive basically all positive cases, and we had to basically risk stratify them to make sure that they are sent to the right quarantine facility or got admitted and got treated. That was fine, but the challenge was that we got a phone call in the morning and we had to open that basically that night. By 11 p.m., everything was ready. And I have to tell you that that was just basically an open space, an old ED space that was not used. We had to revamp that and staff it, do the flow process for those patients, get IT, physician, nurses, and allied pharmacists, radiographers, and everybody set, stock up all the medication, get it all ready, and we did it. And that was a huge and tremendous task. And I think it was a heroic efforts by our team. And these are some of the photos that were taken right before that went on. I wanted, last but not least, I wanted to touch and shed some light on the ICU situation that we've had. We during the renovation of Rahba Hospital, while the acute beds were ready, but the ICU was not, and that was in the next phase, our option was to basically open an ICU in Mafraq Hospital. But prior to that, our sister hospitals, SKMC and SSMC, have helped us a huge deal. The IM department and the ICU department at SKMC have done a great job in helping us to triage those patients fast to them and get them safe to them. SSMC did a great job as well and helped us tremendously. And in fact, they've actually managed our ICU in Mafraq. And the way it was done, and I think that's one of the keys for their success, is that they're specialized teams. And what they've done is that the intensivist team or the ICU team would look after the overall general condition of the patient, to manage all the medical condition of the patient. The procedure team, mainly run by anesthesia, they would do the lines and the intubation. And there was a lot of re-intubation, so they would tackle that. We had a proning team, and as you all know, that to prone an average 70 kg patient would take about an average of 5 staff. So you could only imagine an obese patient. The ICU team and the medicine team were just in close connection at all times. And they would recognize any patients that needed an upgrade to the ICU immediately. And what helped us do that is the concept of the ICON nurse that would screen all those patients, and as well as the radiology department that would just tell us, okay, look, this is not looking so good, and it was a live reporting. I think one of the most, the fondest memories that I have of the successful stories that we've had is our 93-year-old patient. And she was in the ICU and developed delirium when she got into medicine with us. But we've done well in the sense that we've gotten the iPad or the tablets and had her see her family frequently. And I think that helped to discharge her safely home. In conclusion, we've had a lot of love and support from a lot of people, but the special gesture and the gesture of thanks that we've had actually from Her Highness Al Imarat was a great deal. She sent us a delicious gourmet meal on Eid Day, and that was really nice to be surprised with. All of our staff gotten that. And also the Fursan Limarat have done a flyby in appreciation, and this is actually in that memory, the whole team, a Rahba team. And that was a special day to all of us. So in conclusion, our team, the whole, old saying, teamwork makes dream works, has really resonated here, and I cannot thank them enough. And thank you, that's it.
Thank you very much, Dr. Sadia, for this motivational slides, especially the last 2 or 3 slides. So now we will move to Dr. Jihad Abdullah segment. Dr. Jihad is a board certified by the American Board of Internal Medicine and the American Board of Infectious Diseases. Currently, he is infectious disease consultant. He is head of Infection and Prevention Control Committee at Al-Rahba Hospital. He is member of the expert panel and the strategic planning team of tuberculosis in Abu Dhabi Health Authority. His current area of research and teaching interest includes viral infections, TB, multi-drug resistance organisms, and prevention of healthcare associated infections. So Dr. Jihad is going to talk about updates on COVID transmission, and he's going to present very interesting cases. Dr. Jihad, please, you have the mic right now.
Thank you very much for the nice introduction. Let me share my screen. Can you allow me to share the screen? Because I cannot. Someone unshare and then I can share it.
Okay. Reem, can you Dr. Jihad with this? Okay.
Because it says you cannot share it while others are.
Reem, can you give the permission for sharing, please?
So Sajja, maybe you have to unshare first. Stop sharing. Dr. Sajja, maybe you have to stop sharing first.
Dr. Sajja,
I'm trying to get to it. Here we go.
The top, yeah.
Okay.
Yes, now I can.
Okay.
Can you see my screen?
Yes, Doctor, now we can see it. Go ahead.
Okay. So again, thank you very much for the nice introduction. So the objectives for this session is to recognize how COVID-19 is spread, duration of infectivity, and we're going to go through some cases with unusual manifestation of COVID-19. Also, we're going to go through some cases with negative PCR testing, but it's COVID-19 infection. And of course, we're going to recognize some of the unusual chronic complication. So let's start with this case. So this is a 77-year-old male patient with past medical history of diabetes mellitus and hypertension, admitted with fever, body ache, and dry cough, tested positive for COVID-19. He lives with his son's family, which includes the son, wife, and 3 sons. All of them are asymptomatic, no symptoms at all. He usually isolates himself at home. He doesn't go out at all or meet any other people. So how he acquired COVID-19? And the simple answer is this: asymptomatic infection. So what happened, most likely one of the family member had asymptomatic infection and he infected him. Or if it's an early stage, maybe someone with who was pre-symptomatic infected him, but this is unlikely because he doesn't meet any other people outside. So this will lead us to the concept of pre-symptomatic and asymptomatic transmission. For the records, we know that about 60 to 41%, based on one study from China, had like they were asymptomatic completely. So that, let's say 15% of all cases were asymptomatic. Out of these asymptomatic people, they can spread the disease, they can infect others. Also, the other thing is pre-symptomatic infection. Usually, it's estimated that 44%, this is based on one study, 44% of the transmission took place because of pre-symptomatic infection. Someone of the family had infection, met other family members. He was asymptomatic back then completely, left them, and he developed symptoms. And later on, those people who contacted this patient who was, can you go back to one slide before? So so those people who are asymptomatic can spread the disease. Usually it's around 2.5 days prior to the symptoms or prior to the onset of symptoms. So as you can see in this diagram, the dotted line represents infectivity, infectiousness. So the most infectiousness period happens around 2.5 days prior to the onset of symptoms, which is 0 here, and up to 7 to 8 days post symptoms. And as you can see here, the most of them happens 1 day. The most common infection happens, or transmission can happen 1 day prior to the symptoms, to the onset of the symptoms. And the solid line represents the viral load in the nasopharyngeal mucosa or the respiratory tract, and it goes parallel with the infectivity. So the highest viral load, as you can see, is in the 1 day before the onset of symptoms, and it goes 1 or 2 days post symptoms, and it goes down fast. By the time you are about 8 days post symptoms, most likely you have not enough viral load in your respiratory symptoms to infect others. Why this is important? It is extremely important because if we know who is infected, this will help us a lot to do the infection control measures. We can isolate someone who is highly suspicious of getting the disease, ask him to stay home, not go to work. That's why we isolate contacts of infected case. Even if they have no symptoms, we'll ask them to go home, isolate themselves, Nowadays, we told them to isolate themselves for 10 days, because this is the period where we think you can infect others, even though you are asymptomatic completely. After 8 or 9 days, most likely, you have no chance to infect others. And if we know that, also we can do all other infection control recommendation about the hand hygiene, social distancing, and the mask wearing. So let's go through this case. This is a 67 years old female with past medical history of diabetes mellitus, obesity, and hypertension. She was admitted to the ED with fever and cough for 9 days. And I put 9 days in bold because it means something. In the ED, she developed tachypnea and she showed low oxygen saturation, did not improve with oxygen supplement. She was intubated, and the nasopharyngeal PCR testing for SARS-CoV-2 came back negative. The question, is this COVID-19 infection? And if this is really a COVID-19 infection, why the PCR test is negative? And the simple answer, yes, this is COVID-19 infection. And why is the test is negative? We'll show it in this slide. So usually the first 9 days post symptoms, the viral load is highest in the upper respiratory tract. So if you do the PCR in the nasopharyngeal, the way we do it usually, nasopharyngeal space, there's a high likelihood that the test will come back positive. Beyond 9 days, as you can see here, the blue dots are from the saliva, upper respiratory tract, and the red ones from the deep respiratory tract, the bronchus and the alveoli. And as you can see, beyond 9 days, low concentration of the virus in the nasopharyngeal area and higher in the deep respiratory tract, meaning the trachea and the alveoli. That's why if someone has pneumonia and developed shortness of breath, which happens usually after 7 days of the onset of the symptoms, the PCR, if it is negative, does not mean he doesn't have the COVID. If he is intubated, the best practice is to do endotracheal aspirate and get it tested for COVID-19 by PCR. And as I said, pneumonia may develop late, the average 7 days with shortness of breath when the PCR in the upper respiratory tract is negative. The other interesting concept is the airborne transmission. We denied this for many months, and we did not, to be honest, we did not have enough data to suggest that. But nowadays we know that when you are infected with COVID-19, you are, when you cough, when you sneeze, when you talk loud, when you laugh, even when you talk, you propel different sizes of droplets, measuring from one micron to more than that. So anything 5 micron and less can fly in the air, mainly in confined closed areas, and stay in the air, small poorly ventilated areas, rooms, for a few hours, 2 to 3 hours. For example, elevator, when you you get to an elevator and someone is sick and has been in that elevator coughing for a while, it's a good chance that if you are not wearing a mask and you get in and there's very small airdrops, less than 5 micron, flying in that closed atmosphere, it can get to you to that, what you call it, the T-zone, the eyes, nose, and mouth, and infect you. Of course, the larger the droplets, the faster it will drop and stay in surfaces. And for example, if you cough and the droplets are heavy, it will drop right away within a meter, or maybe within 2 meters to one object, let's say on a table, on a phone, on a computer keyboard. Someone comes and touches that non-moving object and then touches his eyes, nose, and mouth. This can transmit the disease. So the concept now, there is no absolute airborne transmission or absolute droplet transmission, something mixed. It depends again on the size of the droplets. And in one study, they found out that a person in early stages of disease, which is like 1 day prior to, let's say, the maximum transmission, 1 day prior to the onset of symptoms, up to a couple of days post onset of symptoms, if he talks, I'm talking about just talking and breathing normally, he can exhale millions of copies of the virus and infect others. And there was a nice video published at New England Journal of Medicine showing what I'm talking about. They showed someone who was supposed to talk, and they monitored his droplets when he talks using what they called laser light scattering technique. And later on, they asked him to wear a mask. So they did this prior to a mask and then post mask. And I wanted to see what happened when he first talked without a mask. So this is without a mask. You can see the scattered droplets everywhere. Now with a mask. Nothing. So nothing, no droplets, no any chance to infect people when you're wearing a mask. So the bottom line, even by talking, by exhaling, you can infect people. So asymptomatic COVID-19 people are contagious, and also 2.5 days prior to the symptoms, you are contagious. And usually asymptomatic people can be contagious up to 8 days. So the bottom line, how can we find those people who are asymptomatic but can transmit the disease? This is the dilemma. And in UAE, we're doing a good job screening people in different places, many stages. When you enter Abu Dhabi, when you come from overseas, apply for anything, you get to the hospital for any reason, you are always tested. This is the best strategy. More screening means more finding of asymptomatic infectious candidates. Because what we're seeing right now is only the tip of the iceberg. What we can't find or we can't recognize are a lot. Now, they recognize that there is certain events, we call it super spreader events, that transmit the disease more than others. In fact, 10% of infected persons are responsible for 80% of SARS-CoV-2 transmission. Imagine only 10% are responsible for 80% of this transmission. And if you prevent those high risk super spreading events, you can prevent the spreading of the disease. What are those? We call it the 3 C's. So the super spreader events are 3 C's. The first C is closed, poorly ventilated indoor space. The next C is crowded area. The third one is close contact, very close to other people. So the current data suggests that exposure risk can be estimated on basis of the following: ventilation. So is there a good ventilation in and out? Windows are open, the air exchange in that closed area is good, or density. Crowded area with many people means high risk. Larger area with less people means less risk. Face coverage, when you're wearing a mask, the likelihood of infected others are way less than the people not wearing a mask. And this is proven in all studies. Exposure duration, getting in one room with poorly ventilation circumstances, dense area for a longer time means higher chance of transmission versus a transient exposure. And of course, activity, any activity that will make you close to people, close contact to people, means higher chance of infecting other people. So the rule of thumb you should know about COVID-19 transmission is the following. Number one, safe distance should be at least 1 meter, and I prefer 2 meters. If not, 1 meter is satisfactory, although not all the time, mainly in closed area. In closed, poorly ventilated area, 1 meter is not enough. Also, more time, as we said, more time for exposure means more risk, and outdoor activity is better than indoor activity. For example, if you go jogging outside, this is a low risk, but going to a closed area and by the way, I'm talking about non-wearing a mask. All those examples when you do not wear a mask. Going to a mall and or grocery shop or whatever, higher risk. And when you sit in a restaurant and indoors, higher risk. That's why we prefer, myself, when I go to a restaurant, I always pick outside, especially now, the weather is great, versus inside. Finally, closed area, closed, poorly ventilated area, like this is like a bar or a club. This is the highest in risk. So let's move to this case. This is a 64 years old male with the past medical history of diabetes mellitus, which is poorly controlled, so he's immunocompromised, admitted with fever, body ache, and dry cough. The nasopharyngeal swab for COVID-19, for SARS-CoV-2 is negative twice. Lung CT scan is showing bilateral peripheral ground glass opacities. And in this example, I did not give you the duration of symptoms. I'll keep it to your imagination. So the PCR is negative. The question, is this COVID-19? And should we start treatment or not? The simple answer is yes, this is COVID-19 infection, because the findings, you see the ground glass opacities, mainly peripheral ones, are classical for COVID-19. And of course, in such a scenario, when patient has pneumonia, we don't delay treatment, we start treatment. So this ground glass opacity is the hallmark for the disease, for COVID-19 infection, which is bilateral peripheral ground glass opacities. Sometimes you might find consolidation, and usually the peak involvement of the lung is at day 6 to day 11 post symptoms. In fact, in China, in Wuhan, at one time they ran out of PCR kits to test for SARS-CoV-2. And when they have a patient with symptoms compatible with the disease, they used to do CT scan of the lung. And if they see such manifestation, the peripheral ground glass opacities, they would automatically isolate and treat. And they found in one study that the CT scan findings are more sensitive than the PCR testing. So again, they found, as I mentioned, that the specific sensitivity and the specificity of that CT scan findings is better than the PCR testing. So let's move to this case. This is a 47 years old female patient diagnosed with COVID-19 pneumonia. She developed urticarial, highly pruritic skin rash in her upper extremities, upper and lower extremities. 5 days after the confirmation, the diagnosis confirmation. The question, is this related to COVID-19 infection or this is something else? And again, urticaria can be a manifestation of drug allergy, possible. Maybe she's allergic to one medication that we gave her, or the important point, it might be also a manifestation of COVID-19. COVID-19 can manifest as such a thing. So let's go back to the primary symptoms of COVID-19, the big ones, the one we know. So COVID-19 can give you, of course, cough, sore throat, it can give you headache, can give you congestion or runny nose, of course, loss of taste and smell. Sometimes it can give you shortness of breath, which is late. Usually it is 7 days post symptoms onset. Fatigue, body aches is very common, as well as fever and chills. And in some cases, you might have GI symptoms, including vomiting and diarrhea. And as we know, the incubation period up to 13 to 14 days, but it can also start 2 days post-exposure. So the incubation period is 2 to, I would say, 13 days, not 14 days. This disease, COVID-19, comes with all colors, all flavors. So either you have an uncomplicated illness, mild, and by the way, the majority of people can have uncomplicated illness, and they estimate that up to 70 to 80% have any complication. It can give you mild pneumonia, or it can give you severe pneumonia. It can progress to ARDS. It can, you can develop sepsis, and you can develop even septic shock. So what about the extrapulmonary manifestation of COVID, the unusual ones? Let's go with the skin manifestation, the one we mentioned in the previous question. It can give you petechia, it can give you something called livido reticalis. We'll go through that, but this is the toes discoloration. We can give you erythema, the erythematous rash. It can give you urticaria as our example, or vesicles like herpes-like lesions. It can give you also perineal-like lesions in the extremities, or it can give you CNS manifestation. I've seen people with encephalopathy, Guillain-Barré, rare, but it can happen. Of course, can give you myalgia, stroke. I've seen people with CVA, because the whole thing about the hallmark about COVID-19 is the thromboembolic phenomenon. So you can have deep venous thrombosis, you can have PE, pulmonary embolism, catheter-related thromboembolism. You can have hepatic involvement, and when you have a patient with COVID and have high LFTs, it might be from the disease, or it might be from the medication we give it to him, the treating medication or the disease itself. Renal involvement, when you have also, you can have acute kidney injury that results in proteinuria and hematuria. And you can have a new onset of hyperglycemia. We've seen people with no history of diabetes mellitus coming with high sugar, even diabetic ketoacidosis. This is when the disease affects the pancreas and causes such manifestation. We've seen cardiac involvement, all kinds of cardiac involvements, including cardiac arrhythmias, myocarditis, ischemia, even cardiogenic shock. We've seen that. Finally, as we mentioned, we can have GI symptoms and anorexia. So let's go back to the dermatological manifestation. This is a very nice study showing the relation between the skin manifestation and the severity of the disease and the outcome or the prognosis. So if you have what we call the pernio, which is the discoloration of the digitals, toes mainly, this is a very mild, represents a very mild disease. The likelihood of hospitalization is only 16%, versus when you have vesicle disease, when you have urticaria, when you have erythema, or you have morbilliform. This means that the likelihood of hospitalization is higher. Now it's up to 45%. Finally, when you have something called retiform purpura, this is a bad prognostic manifestation, skin manifestation, which means that there's a blood clot in the arteries in the subcutaneous, dermal and subcutaneous area, and it's associated with very poor prognosis, 100% hospitalization, and 82% ARDS. Very poor manifestation, very poor prognostic factor. This is the last case. This is 62 years old female with past medical history of diabetes mellitus and obesity, admitted with fever, cough, tachypnea. She was diagnosed with COVID-19 pneumonia, treated. Luckily, she was discharged home and her PCR is negative. She comes to see you in the clinic after 1 month, again, after 30 days. She's still complaining of persistent weakness, chest pain, joints pain, and she's depressed. Is this related to COVID-19 or related to her husband? I'm not sure. So the question is this related to COVID-19? The answer, yes, this is related to COVID-19. So in one study in Italy, they monitored those patients with COVID-19 infection, the one who were hospitalized, and saw them 30 days post-discharge. And they found that 32% of them still having 1 to 2 symptoms, 55% had more than 3 persistent symptoms, but none of them had fever. And all of them had, 44% of them reported low quality of life. So what are the big fives? I call them the big fives. We call, or the chronic manifestation post-COVID, fatigue. This is the most common manifestation. Almost all the patients, up to 80%, will have fatigue. They feel weak all the time. Some of them with still having dyspnea, shortness of breath, even with minimum effort. Arthritis, joint pain is like up to 55%. Chronic cough, up to 60%. So this is the big fives. And of course, chest pain on and off, by the way, non-specific chest pain. But the good news, none of them, as you can see, have fever. So if someone has fever, this is not related to COVID. Check for something else. Of course, reinfection can happen, but extremely rare. I'm talking about COVID-19 reinfection. Keep it in mind, it is extremely rare, especially in the first 60 days when you still have some immunity. Again, no fever and those chronic manifestation. Thank you very much.
Thank you very much, Dr. Jihad, for this informative presentation. So I will have to move now to the questions. I will be very interested to hear comments from the audience. We have around 20 minutes for questions and answers. I will take a few verbal questions, then I will have to use the massive question bank I have right now for each guest, and I will try to distribute the questions equally between the three speakers. So if anybody has verbal question, they can raise their hand, and we will try to take a few comments or questions. Reem, can you help me with that? Because I think we have Dr. Khalid Al-Nakhbi who would like to make a comment. So we have Dr. Saeed. Okay, so we have Dr. Saeed. Okay, Reem, can you just give permission for Dr. Saeed to make a verbal comment? Reem? Because I'm not sure how can I give him permission. So you can do that.
دكتور عمر حضرتك عايز to allow الأوديو؟
Yes, just I will take a few comments or questions from the audience, and then I will ask the written questions I have, because I have many questions for each speaker.
Okay, so you can select, and we will make him or her a panelist, so he will be able to talk.
Okay, can you do that for Saeed Hussein? Because I am seeing that he's raising his hand.
Assalamu alaikum.
Alaikum salam.
Thank you very much for this, all of the speakers. Very nice presentation, and we are waiting for this, and hopefully we will wait for the full result and announcement with the full data. My question is, I am actually in the trial, and I don't know if I am with the placebo or with the true dose vaccine. So when the result will be announced, when we can take the vaccine, and if we have the option to take the Chinese or the Pfizer, which one to take? Thank you.
Okay, thank you very much. I will direct this question to Dr. Nawal Kabi. I received many similar questions that Dr. Nawal, if you have the option to take Moderna, Pfizer, or Sinopharm, or the Russian vaccine, which one would you choose?
Maybe Dr.
Dr.
Nawal
Nawal?
first. Maybe she's in her, okay. And maybe I can answer till she comes back.
Okay, okay. Dr. Jihad, we have many questions for you. So I will just ask some written questions to you. Then when Dr. Nawal is back, we can ask her about the vaccine. So Dr. Jihad, since you spoke about the transmission of the virus, why don't you label coronavirus as an airborne disease instead of like droplet disease?
It is officially airborne disease now by WHO, so it has been recognized as airborne a couple of months ago. So it's officially airborne.
Okay. Now, if I think we have Dr. Nawal as well. Okay. So the second question to you, I received this question from the audience. Now you said the mask will protect other healthy people from getting the infection from the infected subject, but would the mask protect you from getting the infection from sick people around you?
The answer is yes. There is no 100% protection, but it protects a lot, up to 85 to 90%. You know, we noticed the following. If you are wearing a mask and you get infected, you will get a mild disease. Why is that? Because the amount of virus gets to your mucous membranes, the inoculation, the amount of virus inoculated to your mucous membranes will be less than someone not having a mask. And this will allow the immune system to tackle the coming virus and try to eliminate it. The result will be a mild disease versus someone who's not wearing a mask and exposed to a sick person. So even if there is no full protection and you get sick, all the cases I've seen got a mild disease. And I explained why.
Okay. So I will come back for you because I have many questions regarding the vaccine as well. Dr. Saja, we have a question for you. Are you ready for the coming wave or for another pandemic? And since you mentioned that you had some shortage in the specialized physicians, how did you manage to accommodate the increasing number of patients? And if you don't have like the IM or ID physicians, how did you manage?
Are we ready? Yes, we were born ready. We've learned a lot and we have best practices and we're going to implement those. And I think everybody is ready, but hopefully, inshallah, there won't be any second wave. As far as the how did we manage? we've managed as such as allocating each certain amount of patients to be basically cared for non-IM physicians that were trained on our protocols. And we've had the IM physicians supervise all those patients. We had consultants at times with a shortage supervising 70 patients at a time. And they've done that remotely, and they had to go in and examine each single patient if they needed to, perhaps about 5 or 10 patients physically. But done remote, we've eventually got the help, and we're no longer, I'm happy to report that we're no longer short. Thank you.
Okay, Dr. Thank you for your answer. Dr. Jihad, going back to the 1 million question, if you have the choice between taking a Moderna, Pfizer, Sinopharm, or Sinovac, or the Russian vaccine, which one would you choose?
Okay, it's really a difficult question. And it depends on, are you willing to take the risk or not, and how much we know about this vaccine or not, and your immune status, and you have allergies, certain allergies or not. The simple answer for me, I'm going to answer about myself. Myself, I took the Sinopharm vaccine because I know it was made through the conventional way. There's no messenger RNA technique. This strategy or messenger RNA might be the future vaccines, might be the new vaccine method. And but for now, for me, I would like to wait. Others, they might say, let's take it, let's see what happens, and no problem. It's always good to have multiple options, not only forcing you to take one vaccine. It's good. So when you have the options, you can decide, but whether you want to go through the traditional conventional way or the new, I will call it rocket science, the messenger RNA vaccine.
Okay. Thank you, Dr. Jihad, for your answer. Do we have Dr. Nawal? Can she hear us? Okay. Dr. Sajja, I move to the next question. Now, you mentioned that you started the anticoagulation before it was introduced in the guidelines. So the question came to me, shouldn't we wait for the guideline to be like official and published before we start a new treatment, or before we start a new intervention or a new investigation? Like you mentioned, you moved from chest X-ray to CT scan, and you started the anticoagulation. So what should we do in this case?
We've thank you, Dr. Amar, for the question. We've actually started the anticoagulation on the basis of the immobility for those patients, the longer hospital stay, given that they were staying there for 7 to 14 days. Some of the patients actually stayed for a lot longer. And for as long as there was no contraindication, we went ahead and actually started those anticoagulations.
Okay. Okay, I think thank you, Dr. Sajja. We have Dr. Nawal. No, she is back. Dr. Jihad answered some questions regarding the vaccine, but Dr. Nawal, I received one question regarding acute demyelination post-vaccine. Do you have reported cases, and is it significant? Is it related to the current vaccine we have in UAE?
First of all, let me clarify something. Now, with the interim analysis of the study, there was no difference between placebo and the vaccine in terms of serious adverse events. This is one. No difference between a placebo and vaccine when it comes to side effects. And there was a suspected case of very mild demyelination that resolved, and it was not typical. It happened 2 days after the vaccine, and a separate team decided that we decided it is not conclusive, but another team decided this is not related.
Okay, Thank you, Doctor. Dr. Jihad, if the patient has negative PCR, but his CT showed severe disease, does this make the patient less infectious because the PCR or the repeated PCR were negative?
As I said, after the 8th day, most of the viral load is in the lower respiratory tract. So if he coughs, if he sneezes, still contagious. We know that. But just to let you know, people with severe disease can have the viral shedding slightly more than mild cases. If I have a mild disease by day 8, I'm not contagious at all. Severe case can extend up to, let's say, 13 or 14 days. That's why we say if you have a mild disease, by day 9 or 10, you're not contagious. Severe disease up to 2 weeks, and then you're not contagious. So this is it's still contagious, but you have to, but for a longer time, and you have to have more effort to get the deep respiratory tract material out by coughing. So it's not by exhaling or just talking, because it's deep in the bronchus and in the alveoli.
Okay, okay, Doctor. Thank you. Dr. Saja, this question is very common question. Did you see any cardiac complications related to medications like hydroxychloroquine?
We've had a patient actually with the pre-existing, I believe, cardiac issue and cardiac arrhythmias. She was given the first dose, and then we realized that she's had QT prolongation. But that was the only patient that we've had in the thousands, I believe, and that was the only patient that we've reported. We don't think it was related directly to the hydroxychloroquine, but it's yet to be determined. Only one patient.
Okay, thank you, Doctora. Dr. Nawal, do you recommend the COVID vaccine to transplanted patient, the patient who received transplant or cancer patients? Maybe she cannot.
I can answer this if it's okay with you, because I'm involved in
this. Please.
Yes. Sure. So for immunocompromised patients, including transplant patients on immunosuppressive therapy or any immunosuppressing condition, we give the vaccine and we tell them the following: it will not give you side effects. It's not harmful. No side effects. It's just the amount of antibody that you might generate might be less than immunocompetent patients, but we give it no problem. For cancer patients on remission, 6 months and more, we give the vaccine. Cancer patients, no chemo or radiation therapy, for 6 months and more, we give the vaccine, no problem. We tell them the same thing. The antibody formation might be suboptimal, but still protective and recommended.
Okay, Dr. Jihad, I received one question. When would you consider stopping antiviral, anticoagulation, or supportive therapy, especially if the repeated PCR was positive, but the patient was asymptomatic? So when would you consider stopping the treatment?
Yeah, let's talk about the medication we're using, starting with antiviral, remdesivir or favipiravir or camostat. Usually we give it for 7 days if you have mild case, mild to moderate. Moderate to severe, we can expand it up to 10 days. In fact, remdesivir is recommended to be given for 10 days for severe cases. For steroids, and we give now dexamethasone as per the study from England, from Oxford. and we give the dexamethasone for 10 days. Personally, I've noticed that if patient is not improving, or there's some improvement, but still not as we wish, we can extend the duration of dexamethasone up to another 7 days. And I've did it many times. So don't commit to only 10 days for dexamethasone. Finally, for the anticoagulation, this is a very gray zone. And usually they say up to 1 month. But if you have someone with high risk, persistent elevated D dimers, I would keep giving it until the D dimers are down to some acceptable levels. And it might be beyond 1 month. And usually once the patient starts to have good D dimers, we give it once a day. When the D dimers are high, it's a therapeutic dose, and we give the anticoagulation twice a day. So the answer is 2 weeks in general.
2 weeks in general. Okay, that will take me to the next question to Dr. Sajid. Dr. Sajid, have you come encounter to any complications related to anticoagulation?
Yes, we have. In certain individuals, certain patients that are predisposed, it's a tricky basically call, because you have the certain individual now COVID which is a prothrombotic state, but then also they are at risk for bleeding. Their risk at the initiation of the anticoagulation was not an absolute contraindication, and therefore it was sort of like where it's a gray area, and we chose to anticoagulate given the fact that COVID was more life-threatening at that point than the bleeding that we could have recognized and dealt with. Was it caught in time? Absolutely. We've dealt with only one patient that had a subdural, but that was not related to the anticoagulation directly. As far as the other patient, we've dealt with it. We stopped the anticoagulation and resuscitated them. Thank you.
Thank you, Dr. Now I will take one verbal question from Dr. Khalid Al-Naqbi. Reem, can you please allow Dr. Khalid to, can you just unmute him? Sorry.
Dr. Khalid.
Dr. Khalid Al-Naqbi, he's raising his hand.
Yes, salam alaikum.
Alaikum salam. Marhaba, Dr.
Good evening, everybody. Thank you so much for this interesting talks. I've been attending it since actually minute number 1. A very good effort, and it shows that the UAE is ready for any, God forbid, pandemics in the future through the collaboration between you guys and big efforts as well. The major question from us, I'm as some of you know me, a rheumatologist. So many of our patients, actually almost all our patients, ask us a simple question. Am I allowed to take this COVID-19 Chinese killed vaccine? And we keep telling them, unfortunately, we don't have any data on that. And we're really hoping for the Chinese to publish their report. And we hope that maybe in the near future that they will allow some of the immunosuppressed patients, those who are taking biologics or immunosuppressives for lung, for oncology patients, rheumatology, dermatology, and so on. So what is, I just wanted to ask the feeling from the panel, because we don't have the data, the Chinese data. What is the feeling from the panel actually about taking the Chinese killed vaccine in immunocompromised patients?
Okay, Dr. Jihad, we received similar question. Thank you, Dr. Khalid, for your valuable comment. I received also another question from Basim. How safe to use vaccines in patients who is taking DMARDs or biologic for connective tissue disease? So this question goes with the comment of Dr. Khalid as well.
Okay. I think this answer is the same as the cancer patients. Usually, since we started to give the emergency approved vaccine, we decided to give it for immunocompromised patients, including patients getting like strong immunosuppressive therapy, biological agents. And the bottom line, if the patient is asymptomatic, stable, no harm of giving him the vaccine, because the same as influenza vaccine, killed virus vaccine. The fear is that those patients who are immunocompromised might, again, I'm saying might, we're not sure, we're still studying, might not be able to mount enough antibody to say, to get immunity, because we give the vaccine to get immunity, correct? So we don't know it yet. But the bottom line, yes, we give it to patients immunocompromised as long as they are asymptomatic and stable, no active symptoms. But we tell them, you might not be able to get enough antibodies as immunocompetent patients. You might, we don't know, but let's give it, no harm.
Actually, we've been giving it to immune compromised, and good number they did form antibodies. And we do have a solution. If there's no antibodies, we can give a third dose.
But no side effects, the bottom line.
Exactly, no side effect, and it is safe. If you ask me what is the safest vaccine that are available in the market now, we can say with confidence, this is the safest vaccine. It effectiveness, I think it vary. This is inactivated. We vaccinate a lot of people, several hundred thousands, with no single admission with COVID among those. So this is a bonus when it comes. We are monitoring all the positive PCR, and they are very, very small. And even those who got positive PCR, either asymptomatic or have common cold-like symptoms, rather than pneumonia or severe disease. And this is a very important part, I think, for the vaccine. You want to prevent the severe disease, you want to prevent admission, and you want to prevent pneumonia.
The way we rheumatologists look at the inactivated vaccine is similar to looking at pneumococcus and influenza. And
Yes.
the consensus among the rheumatologists, also the infectious disease in the guidelines, the previous guidelines, is to stop the methotrexate or azathioprine or mycophenolate mofetils for like 1 or 2 weeks, better for 2 weeks. Again, assuming the patient is stable from autoimmune disease. But for those who have active disease, we say, you know what, forget about this vaccine. It's not the right time. Also, prednisolone, we'd like to lower the steroid less than 15 milligrams. So these are just general guidelines. And what I say in my clinic, I said, if you choose as a patient to take it, I don't have any data. I'm still waiting for the Chinese to publish something. But if you choose, then you need to stop your drug for like 2 weeks before you resume them again. But I don't have anything for biologics. The consensus about biologics is that all of them are fine for influenza and pneumococcus, except obviously rituximab, which will wipe out the B cells. So it might not be useful. General guidelines that we use from our past experience, but yet to know about the inactivated. My feeling is the inactivated vaccine would be probably better than other vaccines. Thank you very much.
Thank you, Dr. Khalid. Dr. Nawal, we have one question. Would the current vaccines we have in UAE or outside UAE cover the new mutations? Because every day we hear that there is new mutations among the coronavirus in Europe and Africa. So would the vaccine cover the new mutations?
Okay, I can answer for the inactivated vaccine. Now, inactivated vaccine, it's a whole virus that is inactivated. It's not just part of the protein or part of the spikes. So if you are using a whole virus, it is very likely that it will cover most of the mutations. To reassure everybody, actually, currently we are testing it, and the testing will take time as we have to culture the virus and test it. But we anticipate it's going to work, and as soon as we hear the result, maybe they will announce it. But I think it will cover it. We have one of the rare mutation. She was not vaccinated, but her family vaccinated, and none of them got the disease.
Okay. Now, last question, Dr. Nawal. Many people were asking, do you have the updated version of the guidelines for management of COVID? Because last update was in July.
Yes.
So,
The
you have
team,
updated.
yes, there will be soon. We will circulate an updated guideline. And
Okay.
currently, we are working also with the GCC. The GCC will issue another updated guideline that will be distributed to all GCC countries.
Inshallah. Thank you very much, Dr. Nawal. Now, before I conclude, Dr. Saja, Dr. Jihad, Dr. Nawal, if you have any comment or you want to elaborate more on some answers, we have 1 or 2 minutes to do so.
I think I
Dr.
saw
Nawal.
one. Yes, I saw
Dr.
one
Nawal.
question. Yeah, I saw one question. If they can take both Pfizer and Sinopharm, the recommendation now, if you choose one vaccine, continue with the same vaccine. I can tell you for inactivated, if you decide to take inactivated vaccine this year, next year, if we learn that there is another vaccine that are better, we can take it. It will not stop you from taking a different vaccine in the future. But please, if you choose one vaccine, stay with the same vaccine, as most of the vaccine require 2 doses.
Okay, Doctor. Thank you very much. Dr. Jihad?
I want to emphasize on prevention. Prevention is the main thing in COVID treatment. Prevent the disease, be proactive, wear a mask, keep distance from other people, unnecessary gathering shouldn't, avoid unnecessary gathering. So prevention is much better than treatment.
Dr. Jihad, we have 600 people in this room. This included, it's virtual. Dr. Sajjah, do you have a final comment?
I just want to echo what Dr. Jihad have said. Basically, prevention is the key, and to re-emphasize on all of this. But I also want to say that we are ready. We have a great government behind us, and we're ready to tackle any second wave. Thank you.
Thank you. So I would like to thank you for taking time out to attend this webinar, and I would like to thank our distinguished guests for sharing their valuable experience with us. Hope to see you all in another educational session with Emirates Society of Internal Medicine. Have a lovely and happy new year. Goodbye 2020, and I will see you next year, inshallah. Thank you very much.
Thank you.